Right now, we used to. I think the first application of ctDNA in lung cancer was in the era of first generation EGFR TKIs, when we were using gefitinib and erlotinib, and we were looking for the T790M resistance mutation, because we know that those patients with T790M resistance mutation, they were eligible for osimertinib in second line, and we could detect T790M in blood. That was a single gene testing. Now that osimertinib is given in first line, we know that that's not something that we do in clinical practice, and now we are moving to a compelling number of applications for ctDNA I think in stage 4 lung cancer, non-small cell lung cancer, not only for accelerating time to treatment, but also for treatment monitoring to assess the response to treatment based on this. We still don't have clinical utility evidence to do this, but there are a lot of trials ongoing to explore this, also to identify mechanisms of resistance to targeted therapies in advanced disease. And there is also a lot of research ongoing in early stage for minimal residual disease detection, which is very promising. This morning they presented a lot of data about this in other tumor types, colon cancer, breast cancer, and I think this is going to be also a very relevant issue in lung cancer. Then I think for screening, this is going to be more challenging. I think we are far from that, but I think the research in this field is moving fast, and it's very encouraging, all the data that we have. But I think that our study sheds some light and open a door about this plasma-first approach, and we think that liquid biopsy upfront can accelerate time to treatment and can increase the access to targeted therapies in patients with advanced lung cancer. And a lot of very interesting data coming in the next few years, I hope.